closure was announced, they couldn't come back. The little money that they had on them, the little monies, they started using them, and now they are broke. So we say they are destitute. As a result, even if you make an appeal, or even if you provide an aircraft and ask these people to pay, they cannot pay. Okay, so these were the categories that we found. Now, in terms of the phase, the names or the numbers were such that at the government cannot take a decision that, okay, all of these people should come at the same time. No, it's going to be very chaotic. Because if you look at the numbers, they were to even be quarantined when they got in, the kind of kits and all that. So the decision was taken that, okay, let's start with the curators. And with this, we said that before they are brought in, firstly, they would have to make sure that they've undergone the test. So this group of people who are initially we were told the number was 245, but subsequently when they landed and we did the reconciliation, we arrived at 230. So they underwent the test, they went through the test, and they were issued a certificate on the day of departure. So that day, this group of people, that's the phase one, they landed on Saturday in Accra. They were all there, led by the Minister of Aviation who received these people. And the process was so harmoniously done to the extent that there was no fault in terms of how this process went through. And probably, let me also give kudos to the national security structure and some of the key government agencies that were part of this operation. Prior to this, their landing on Saturday, we had gone through a simulation process, a simulation exercise that went on so smoothly. So when they landed, we just had to activate these protocols. They went through their, the normal immigration and all that. And by 1 hour, they had gone through all the processes, the needed processes, and they were taken to wherever the Ministry of Health took them. Let me use this platform to thank all those who contributed to that success, because it went on so smoothly. I want to thank the National Security apparatus again. I also want to thank the Ministry of Foreign Affairs, the officers there, because they also did a yeoman's job, starting from our mission in Kuwait. Then the Ministry of Health, through the Ghana Health Service, the Ambulance Service, the Ministry of Interior, through the Police, Fire Service and Immigration, the Ministry of Defense, through the Ghana Army, the Ministry of Aviation, the Ghana Airport Authority and the Aviation Security, the Ministry of Transport, they provided Ayalolo buses to convey our compatriots after having gone through this, the immigration procedure. And last but not the least, NADMO. NADMO also played a yeoman's job. And you yourself, the media, because you were there, to capture, to send the pictures out there, for Ghanaians to see that government really listened to the cries of, her people. We had an agreement with the Kuwaiti government. They brought the people down for everybody to see that the people have landed. And I want to thank you and say that this is the first of a series of what is yet to happen. And as and when we are ready for the next group, it will be announced to you through the same platform that was announced. Thank you for your kind attention.
Thank you.
Thank you, Honorable Deputy Minister, for your detailed update. For our next brief, we would have the dynamics of the coronavirus. During the lockdown, it was explained that the lockdown was for the purpose of enabling our health professionals to go out and gather enough data to be able to assess the dynamics of the coronavirus here in Ghana. As we all know, looking at the global data, the virus behaves differently in other countries. And we needed to know how the impact and how its dynamics here in Ghana. So we did get some data and some analysis during the lockdown. And every now and then, the assessment and data gathering is ongoing. So we would invite Dr. Bedu Sarkodie to come up here and then update us on the dynamics of the coronavirus here in Ghana.
Thank you very much, Honorable Deputy. Good morning, distinguished ladies and gentlemen. My task is very simple: to provide the updates on the dynamics of coronavirus in Ghana. And this is a pandemic which is not restricted to Ghana. So I'll use some of the data for comparison from other countries and try to answer the question as much as possible. When someone is exposed to the germ or the virus, there are a series of activities that will go on within the virus and also within the person. And it starts from anybody who is susceptible. That means that when you are exposed to the virus, you can have infection. And being a new virus that no one has full-blown immunity, almost the entire population in Ghana, as well as the entire global community, are susceptible. Those exposed, susceptible exposure, you may be infected or you may skip the infection. So not everybody who is exposed that gets infected. Indeed, studies are ongoing, and sooner you have the proportion that are exposed that are infected, but these are not very clear out there. Those that are infected, a big proportion may be symptomatic or signs and symptoms. A big proportion may also not show any symptoms at all. If you develop the disease, it may be a mild disease, moderate, severe, critically ill, and some of them proceed to death. This is not one-way journey. From those at any point, when you develop the disease is mild, it can go back to non-infected. And then also when you are moderate, you can recover. Then a few of them may succumb to this or possibly die. The more severe the condition, moving to critical illness, then the likelihood and chance of death increases. In Ghana, we have 32 people that have succumbed to the virus as of now. We move into some of the characteristics of the virus. This is general, not related to Ghana alone. The COVID-19 disease is a coronavirus. The name of this germ is SARS-CoV-2. Often we interchange this, but not interchangeable. When you are talking about the malaria disease, you have to talk about the parasite, which is the plasmodium. So let's get this right. Genetically, the SARS-CoV-2 is very similar to other human respiratory viruses. And then the SARS-CoV-2 infection starts as a small particle, enters the body germ or body cells, and then forces the body cells to make a lot of changes in that cells and pushes the body cells to replicate that virus into itself. And that is how we get the infection, number of germs to the person, and then they can also transmit to others. The SARS-CoV-2 infects cells that have specific protein in the tissue. It's getting a bit technical, bear with me. I'll do best to explain in the simpler terms. And this ACE2 what the virus uses to enable it to enter or penetrate the body cells. And then the more the body tissue has this ACE2, the enzyme, the likelihood the germ can enter it and cause destruction. And the organs and tissues within the body that have this include the respiratory tissues and then also gastrointestinal tissues. Some of the cells have some miniature aspect of this ACE2 or the protein. The SARS-CoV-2, the spread is from person to person, and then later you go a bit into the details. How does the virus make people sick? The virus of COVID-19, the SARS-CoV-2, grows in a specific type of cells, and how they penetrate, I've mentioned them. Within the lungs, they penetrate the lungs, make some secretions, and then use this to enter the cells. The virus damages the tissues of the host, and in attempt for the body to defend itself and repair itself, it brings quite a number of cells that come in trying to attack the virus, also end up forming certain outputs that may not be very tolerable to the body, and this is how the disease starts. It disseminates a lot within the lungs, then the respiratory symptoms, the breathing difficulty, and those other conditions do happen. Millions of cells from the immune system invade the infected tissue and cause massive amount of damage in the process of trying to clean up. That is how it ends. We as health workers, the challenge that we have, how do we support this individual or this condition as the body is trying to repair itself? There is a sliding scale behavior of this virus, and the virus, those children under 10 years, they clear the virus rapidly, and those people under 40 years, up to 10 to 40, when they become diseased, they recover earlier. I'm mentioning this so that when we compare this to the figures in Ghana, you'll see how we behave, we stand as a country. And the same protein, the ACE2, that helps the virus to enter, the same mechanism that the body uses to regulate the blood pressure competes with it. So if the virus goes there first, the body cannot control the blood pressure. So we realize that people with high BP, the hypertensives, when they have the infection, then the tendency to be severe, critically ill, and unfortunately succumbing to the germ is high. That is why when we mention comorbidity, the status of those people infected that develop symptoms, don't develop symptoms at all. About 9% of the people infected develop signs and symptoms. We say they are symptomatic, and up to about 91% have no signs and symptoms at all. Let me come to some aspects of the transmission. COVID-19 is transmitted mostly through droplets and fomites during close, unprotected contacts. Close, unprotected contacts. So when you're preaching, use face masks, wash your hands. These are protective mechanisms. So in close relation, these etiquettes, these principles, these protective mechanisms should be adhered to in most strictest terms. Airborne spread has not been 10% of them may develop the infection. But let's remember, the dynamics in China is not the same as that in Ghana. Still, an aspect of transmission, individual risks also depend on a number of factors. How frequently do you touch contaminated surfaces? mentioned quite a number of times that when the virus is thrown out there through sneezing, coughing, talking, singing, and the germ drops on body surfaces, touch such surfaces, and rub your eyes, rub your nose, touch your mouth, or put your hand in the mouth without having adequately cleansed the hand, you can get the infection. So the risk factors depend on how you touch surfaces, how frequently you rub your eyes, rub your nostrils, put your hand unprotected, unclean hand into the mouth. And then clearly frequent cleansing of bodies, which we call fomites, areas that can be common source of transmission like door handles, doorknobs, surfaces like here, mobile phone, if you share mobile phone, in the offices, if you share pens, somebody infected, if you share the pen of such individual, the likelihood of getting the infection from somebody is high. So you have to take note of this and then see how to prevent and protect against the virus. Healthcare setting potentially could be a source of transmission. We have some big name for it called nosocomial transmission. We have quite a number of health workers that have been infected here in the country in other areas, but clearly it has not been demonstrated that the healthcare setting and health workers are a source of transmission of this virus in the country. This has come from training the people to know how they would use the requisite preventive protective equipment to protect themselves. If unfortunately they have any signs and symptoms, we have to report early. Unfortunately, if they develop any condition, how do they handle themselves and be truthful and sincere and faithful to the people of Ghana so that they report and they get the needed support without transmitting the germ through health service delivery. We have not had any instance where the healthcare setting has been a source of transmission in the country. There are certain settings, like the prisons, where we have a lot of congestion. Should there be infection there, the likelihood of transmission is high. So we need to develop mechanisms to ensure that we protect the inmates adequately so that nobody goes into these areas with the infection. And that will require that probably should there be somebody moving from out to the inmates where the people have been there for some time. We have quarantine cells for them to stay there and make sure we screen them and ensure they are free of the virus. Progression and severity and outcome. The severity of COVID-19, I wish to say, varies. The disease may take a mild mode without any symptoms, and then it may resemble any acute respiratory illness. The mild cases typically recover within 2 weeks, and the viral shedding is complete. In the extreme, when they are admitted, sent to hospital, some of them made to intensive care. It may end up to 8 weeks. So if they don't die, unfortunately, they may recover. Children form a small proportion of those cases reported, and children under 10 are about 1%. Those 10 to 19 years of age form about 4%. Children are likely to have milder signs and symptoms and lower chance of severe disease than adults. The risk of death is about 0.5% among people that are young, and here in Ghana, it seems to be leading the entire or the total fatality rate for us as a country. Pregnant women may be at high risk, but then some studies also, that study the H1N1 outbreak indicates that this virus doesn't seem to have preference for pregnant women, and that the reduction of their immunity doesn't seem to have. But then it's still a new virus that we are studying. We cannot be very complacent on this. So we have to take steps to protect our pregnant women. Still on the severity, severe cases are defined as rapid breathing, that's tachypnea, because it affects the respiratory system, and then often the breathing rate does not reach up to 20. So if you have breathing 30 and over, you say you have tachypnea, it means that the rate of breathing is faster than what is expected. The oxygen saturation tells us how the oxygen air that you are breathing enters the body and provides the necessary oxygenation to the body. And if the pressure, the flow meter of the oxygen comes to less than 300 meters per mercury, then the saturation is low. And these are things that we monitor when we are monitoring the cases to ensure that the saturation is within reasonable range. Critical cases are defined as respiratory failure or other essential organ failure requiring mechanical support or life support. And as much as possible, the baby shock, other organ failure, including kidney failure, are some of the end results. And these, unfortunately, are some of the reasons that some people succumb to it. About 25% of severe and critical cases would require mechanical ventilation, and as a country, we need to prepare for it. And those that will require oxygenation come to about 75%. With regard to comorbidity and death, the overall case fatality rate and the location of transmission. In China, it was earlier high and later it dropped. I'll come to the figures in China later. I mentioned China because that's where the infection started, and we have had enough time to study the virus adequately, and we need to use some of their reports. And the case fatality was high, later it dropped. The mortality increases with age. I mentioned it earlier. The older you are with the infection, the likelihood of developing severe illness, and those with severe illness, the older you are, the unfortunate events may happen, and it's death, and it happens with increasing age. There is the need and call for protection of those that are vulnerable. We are mentioning this not just for the sake of mentioning, but if somebody is old, the person is likely to develop severe illness. So if we are putting in mechanisms to prevent and protect against the infection, these are priority group of population that we need to protect. Those that are old and develop the infection, when it's severe, the likelihood of moving to the unfortunate event of death is also high. So those that are managing the cases have to put in measures to protect and monitor this old and aged very well, because they are at risk of moving to the unfortunate end, the death that cannot be reversed. Most of the people who die have pre-existing underlying conditions. These conditions are hypertension, diabetes, mellitus, cardiovascular diseases, and those with chronic respiratory conditions are also higher at risk. According to some reports, the median time between onset of symptoms to death I'll mention is about 10 days on the average, and 5 days in hospitalization. Some of these people will succumb to it. The median time for exhibiting initial symptoms to death, mentioned earlier, 14 days, and may range from 6 to 41 days. Smokers have been observed to be higher at risk of death, and also with severe signs and symptoms when they get the infection. So we have to also, in our message for prevention, we need to discuss this. What are some of the response strategies? Clear the strategies developed here in Ghana with the goal to prevent and protect against. We have segregated them into districts with cases, those without cases with hotspots. The districts and areas without cases, the strategy is to strictly prevent introduction. This requires quarantine facilities, temperature monitoring, and then also strengthening triaging when people are entering these areas. So it's very important. The areas with sporadic cases, there are some districts with 1 or 2 cases. We need to mobilize the various response actions, and then also prevent further importation, prevent exportation from this area, and strengthen treatment mechanism. Areas with community transmission and hotspots, there's a need to, in the most strict sense, the various prevention and control measures have to be adhered to. And we have to put in mechanisms for isolation, contact tracing, and all those good things, treaties that have been put in place, we go by it. Based on care and treatment, patients are treated according to the National Treatment Protocol and guideline. No specific antiviral agent available as of now. There are some that we are using that even some of them raising questions. So what we do, provide the needed support for signs and symptoms, and then also supportive treatment if they require any ventilation and other organ support to let this person survive the critical age and come back to life. All patients are monitored using pulse oximeter, supportive treatment is implanted for all of them. Treatment using the various approved guidelines from areas and countries that developed the condition earlier is what we are using here. Some of the conditions, even comments have started coming on them. You review this, and if you need to revise our treatment regimen, you do that accordingly. Patients are described after clinical recovery that for 3 days there's no fever, and that for 2 consecutive periods at 24 to 48 hours, this person, having been positive, has later tested negative, 2 successive interval periods, and then reverted to negative. Upon discharge, we ask such a person to continue to adhere to the various preventive mechanisms that have been outlined earlier for the general population. The chart that you will see next is the sex distribution for those in the country that are infected. And then earlier, the male, female about the same. At the point in time, the male take over, and then more preponderance for men in the country. The next chart is the distribution of the entire number of cases that we had as a country plotted against the time samples were taken. This chart should have been best if the people are coming to the hospital, you ask them when the signs and symptoms started. The model that we adopted as a country, Ghana, you don't wait for people to get sick before you go to them, and you go to their homes. Not most of them, with most of them not coming to the hospital. So when the signs and symptoms started, you may not have all, because even majority, more than 50%, may not have any signs and symptoms at all. The best closer to this should have been when they went to the hospital, the time they were seen. Again, most of the people, we visited them to the homes and not waiting for them to go to hospital before we tested them and identified them and started supporting them. So again, that data is challenging. The closest is when the sample was taken, and that is what has led us to this chart. Those that have died, the next slide is what we see here. And I think there is no day that we have more than 3 deaths, more than 2 deaths. The maximum number of deaths for a day is 2. And that is the situation in Ghana. The next few slides, just putting them together, the admissions, the discharge, the deaths, tested ones, tested 2 negative. These are the situation that we have. You use East Hospital, Municipal Hospital. That is where you have the majority of the cases, and that is the situation that we have. The next few charts up to where you have the guide, the continual charts are all about admissions, about the deaths, about discharges. The comorbid conditions, move on, yes. We have total number of deaths for now stand up to 32. What we have here, when we add them up, they will not add up to 32 because one person may have 2, 3, or more comorbid conditions. And we put them based on the number of comorbidity that are available. And the commonest is hypertension, followed by diabetes, asthma, and the rest that you can see out there. Then the proportion that have comorbid conditions are 9.4, and those, proportion without any comorbid condition, 9.4, and those with comorbidity, 90.6. Again, the next slide is what is happening here in the country with regards to the various deaths. And the chart here, next one. Yes, the sex and age distribution of the various deaths, and you realize that clearly as you progress along the age brackets, the risk of death increases. And then the distribution of deaths by region is what we have the next chart. And then the cumulative number of recoveries. You realize that it was down for some time. The people, at a short time, Ghana, we tested and got quite a number of them that were not due for assessment for recovery. When we were ready to assess them for recovery, there were also quite a number of people that were waiting for their results to inform how you should manage them. So priority was provided to these people. So there was a bit of laboratory challenge with respect to when to do these things. And then at a point in time, when the pressure on the lab reduced, we started testing these people that have been observed for more than 14 days and were due for reassessment as recovery. And this is the picture that we have. As we speak now, we continue getting more and more reports from the region. And even before we leave here, the situation may change. Honorable Minister, Honorable Senior Minister, distinguished ladies and gentlemen, I will summarize and conclude saying the following. COVID-19 pandemic is ongoing and active in a number of countries, including Ghana. Ghana started the year 2000 preparing for COVID-19. At that time, we had an alert based on what was happening in Wuhan, China. At a point in time, we moved from our preparedness mode to response when, on the 12th of March, we confirmed our first case. We immediately switched from preparedness to response mode, and a number of interventions and response actions were put in place, which includes border closure, restriction in social gathering, social and physical distancing, the use of face masks, enhanced hand hygiene, enhanced respiratory hygiene, and others. These are the non-pharmaceutical interventions that are key to control the pandemic as we await the discovery of vaccine and cure for this virus. The NPIs, or the non-pharmaceutical interventions, have impacted positively here in Ghana in respect with our morbidity burden and also the death burden. If you compare to a lot of other countries, the morbidity seems to be acceptably low, and then the death toll also up to 0.5% or 5 in 1,000. Indeed, when you compare to other countries, this is acceptable. The virus is here to stay. We need to agree on which of these measures we can adapt and institutionalize for long-term use as we plan to live with the virus in good health and mitigate the socio-economic impact. Your Honor, Senior Minister, Your Honor, Deputy Minister, I think I'll end here for now. And I thank you very much for the opportunity.
Thank you, Dr. Bedu Sarkodie, for the elaborate analysis on the dynamics of the coronavirus here in Ghana. We can only get better and act better with this kind of detailed information. With your permission, I would like to acknowledge the presence of the Honorable Senior Minister, the Honorable Yao Osafo Mafo. In my earlier intro, I left out one major brief that we'll be having today, which is part of our topics today, which will be the deployment of 10 additional ventilators to selected health institutions. So later this morning, the government of Ghana will receive 10 pieces of ventilators from the P-Wood Limited and Temabonde Terminal as their contribution to support the efforts of government of Ghana in the handling and management of the pandemic in this country. The ventilators being donated this morning have the same specifications as those being ordered by the Ministry of Health. And the Honorable Senior Minister right here will receive it when we are ready on behalf of government. For now, we'll take our update on case count and case management from Dr. Patrick Kuma Abuaji. Please come up.
Thank you very much, and good morning all. Honorable Senior Minister, Deputy Ministers, colleagues, and the media, I think Dr. Bedu Sarkodie has made my work a lot easier. I don't have to do too much explanation about why we have certain figures and why we are managing them. So I'll be as brief as possible. As at 24th of May 21st, a total of 156 new cases have been recorded in Ghana. And this shows the new trend of showing much fewer cases. The cases were identified in 5 out of the 16 regions. Greater Accra contributing about 72 new cases. Western region, 57. Central region, 13 cases. Volta region reported an increase in 10, and Ashanti recording probably the lowest figure ever of 4 new cases in a day. We will do more about Western region, which is becoming a new hotspot, a phenomenon that we have gotten used to now. So if you go into the full details, you will see that based on all that, the total count, cumulative count, in the country is 6,964 cases, out of which 2,097 have recovered, and I'll keep on saying that this is still a tip on the iceberg because as we ramp up testing of those who are recovered, we'll get a lot more. There are 15 cases who are severe. I'll give you details of where they are. And as Dr. Bedu Sarkodie said, those who are critical, we don't have anybody who is in the critical condition, they don't need any ventilator. We have recorded 32 deaths so far. For the confirmed cases and treatment outcomes, out of the 15 cases that I say are severe, none is on ventilator, so there's nothing, nobody is critical. We have 4 at the UGMC, that's University of Ghana Medical Center. Ghana East has 3, Ho Teaching Hospital has 1, Kolebu Teaching Hospital have 1 in their world, Kumasi 3, Kumasi has Konfanoche, and Tet Military Hospital has 1. We have about 800 people in isolation across the country. About half of that, or more than half of that, are in Accra, the Pentecost Convention Center, and the rest are in various centers, isolation centers in Ashanti, and some of them are in hotels in the rest of the region being isolated. When you go into the regional distribution, the next slide, as I mentioned, we have had about 10 regions have not reported a case. Greater Accra, the details are there. So they have so far 35 cases, accounting for more than 80-85% of all the cases in the country. We have Ashanti recording 1,062, but they have 4 new cases today. Central has a cumulative figure of 306 with 13 new cases, and I'll give you the details of where the districts are coming from, because those are very important to us. Eastern has not reported a case for a while. Upper West, Upper East have also not recovered a case for a while. In fact, most of the cases in Upper East, they've almost all recovered, and so one can probably start seeing them some level of clean sheets. In fact, their treatment center is temporarily closed until they have a new case. Volta has 10 new cases, but they have OT has 26 cases. They've not had any new cases since then. And then we have Western North has had 2, 1 died, and 1 has recovered. And so they are probably in the same state of currently no case. But this is not to say that because of that, there's no doing a lot of civil. Northern also did not show any case. So broadly, this is where we have. The new issue is the distribution. In the distribution, we still have the same number of core districts in Greater Accra. The next slide, please. Yeah. Where it's mainly in the Accra metropolis, a bit of Tema, Shama. Even Tema is showing some decline, but because this figure is showing cumulative figure, you think that there's calving, but they are virtually not on the list of people who have been presenting positives today. Ashanti region also remains another key area where the Kumasi Metro and Obuasi, but Obuasi is really under control and they are reporting virtually no case now. The new case has come up. The new hotspot is in Western region, who reported about 57 new cases. And these are currently we're going to do, because they look like one of the new hospitals surgeon is mainly the Takoradi, Secondary Takoradi municipality and Metropolis, and then Takwa. So a team will be going there to see how we can quickly assist the region to bring it under control the same way we did in Obuasi. Even though the region has already isolated and identified, self-isolated the people and are doing enhanced contact tracing to create containment. We have had a new case, the first case in Savannah. And this is the very first case that they had. This is a 31-year-old who works in Salaga but lives in Tamale. The sample was taken on the 15th as part of our enhanced surveillance. The regions that do not have a case, they continue doing searches of at-risk people, and this is how this person was picked. So the case was picked in East Gonja. The person is asymptomatic. He's cooperative and has in self-isolation in Tamale. He had 12 contacts. The region had identified 12 contacts, some in Savannah and some in Northern region, and they are all being followed up for the next 40 days. The daily follow-up and clinical review by psychologists has always been done, and this is ongoing. Before I go, I think I also want to add a bit about the team, the people in who returned from Kuwait. On Sunday, about 230 of them had their samples taken. They are currently in the lab. Once we get the results, those who are positive will be moved to the treatment or isolation center, depending on what their situation is, and we watch them, and then within the 14 days, samples will be taken as part of our contribution to the exercise. We have health workers there. We have doctors, nurses, and ambulance services there stationed at the center to provide full care, including psychologists to provide them with care. So, ladies and gentlemen, in conclusion, we continue to see more raging sentences, not reporting new cases. And we also having reducing incidence of cases in the last few weeks. The phenomenon of periodic flare-ups of cases in certain communities continue to come up. This one is more about the Takwa and the Takwari, but the response remains swift, and we gather all our energies to go there and contain it. The deaths, as has been said by Dr. Producer Akodie, also remain low and stable, and we are hoping that this will continue as we fight this disruptive virus. Thank you very much.
Dr. Patrick Aboagye, we are grateful. At this point, I think we can start with our questions. If there are any questions, please come up. Because of social distancing, we have some of the media houses here, the representatives of the media houses here, and then there are some others who have sent their questions on social media to Kweku. So as and when we are done with the questions here in-house, we'll take the ones that were sent to Kweku directly. If you can space up a little bit more, please.
Good morning. My name is Selom Amenya. I work with TV3. So my question first goes to the Deputy Foreign Affairs Minister. In your briefing, you said that looking at the numbers involved, government couldn't have evacuated all the Ghanaians outside at a time. So we want to know what are the numbers. Beyond that, is there a firm decision by government to evacuate Ghanaians abroad? Also, we have news that some Ghanaians stranded in Holland are going to come back home because those who are also from Holland stranded here are also being allowed to go back home. We want to know whether you can confirm that for us. And then to the Director General of the Ghana Health Service, the WHO has stopped trials with hydroxychloroquine. So we want to know what the position of Ghana is on. Are we using it, and then have we used it on anyone that probably died afterwards? Thank you.
My name is Komla Adom. I work with Joy News. A couple of questions. I want to know if there's been an amount or a figure put to the treatment and the testing of these 6,000 plus people that have tested positive so far, and the treatment that has been given to them. Plus, to the Deputy Foreign Affairs Minister.
Can you come back again?
How much has it cost the country to test and treat the over 6,000 people that we have who have succumbed to COVID-19 so far? And also, how much did it cost us to liaise with the Kuwaiti government to get the 230 returnees back in the country? Then my other question to the Director General of Ghana Health Service. We continue to hear stories about PPEs. I'm even fatigued and tired about hearing these things, but we keep hearing them. The Ghana Registered Nurses and Midwives Association recently said about 288 of their members, at the time we spoke to them, were on quarantine. The last time we spoke to them, 41 of them had tested positive. Now it's crossed 50 or 60 actually. Is it the case that these frontline workers who are helping us live are not well protected enough to do the job they do, that they keep getting infected? And I'll give a quote from the General Secretary of the Registered Nurses Association, who says these individuals who are testing positive, surprisingly, are not those who are working in the treatment centers. These are people who are on the periphery, as he calls them. What is happening? Thank you.
My name is Derek Adote from Metro TV. My first question goes to the Deputy Foreign Minister. I want to clarify, are the Ghanaians coming from Kuwait